Rapidly progressive osteoarthritis of the hip, or RPOH, is a rare but severe condition that can lead to rapid joint destruction within a short period. Unlike typical osteoarthritis, which progresses slowly over years, RPOH can cause significant damage in just months. Early diagnosis is crucial, yet it remains challenging due to the lack of unified guidelines and standardized criteria. In this video, we'll explore the latest insights into the early detection and intervention strategies for RPOH, focusing on what makes this disease unique and why timely action is so important for patient outcomes. Early diagnosis of RPOH is vital because the disease can quickly progress to extensive bone destruction, making surgical treatment more difficult and reducing the chances of successful recovery. Unfortunately, current diagnostic criteria often require a 12-month follow-up, which delays intervention. This delay can result in poor outcomes, especially after procedures like total hip arthroplasty. Understanding the early warning signs and risk factors can help clinicians intervene before irreversible damage occurs, improving both quality of life and long-term prognosis for patients. RPOH, also known as rapidly destructive arthritis or coxopathy, is characterized by rapid chondrolysis, meaning the cartilage in the hip joint breaks down quickly. This leads to joint space narrowing, and in some cases, destruction of the femoral head and acetabulum within 6 to 24 months. Some patients experience only joint space narrowing without bone destruction, while others progress to severe joint deformity. The unpredictable nature of RPOH progression makes early identification and classification essential for effective management. Most widely used diagnostic criteria for RPOH include a joint space narrowing of more than 2 per year, or a loss of over 50% of joint space within a year, without evidence of other rapidly progressive arthropathies. Some definitions also consider bone loss exceeding 5 per year. However, these criteria require long-term follow-up, which is not ideal for early intervention. There is a pressing need for more immediate and reliable diagnostic tools that can identify RPOH in its earliest stages. Several classification systems exist for RPOH, but most focus on changes observed over months or years. Recent research has identified 2 main types of early-stage RPOH, one with joint space narrowing but no femoral head destruction within 12 months, and another with both rapid joint space narrowing and femoral head destruction within the same timeframe. This new classification system could help clinicians recognize and treat RPOH earlier, potentially preventing severe joint damage. One of the hallmark features of RPOH is the sudden and severe onset of hip pain. Unlike the gradual discomfort seen in typical osteoarthritis, RPOH pain is acute and often worsens at night, severely impacting sleep and daily activities. This intense pain, especially when the hip appears normal on initial radiographs, should raise suspicion for RPOH and prompt further investigation, even if other signs are subtle or absent. Early RPOH, patients often retain a normal passive range of motion in the affected hip. However, active movements, especially those involving weight-bearing, can provoke excruciating pain. This combination, normal passive motion but painful active motion, is distinctive for RPOH and helps differentiate it from other hip disorders. Recognizing this pattern can guide clinicians toward more targeted diagnostic imaging and management. Early imaging findings in RPOH can be subtle. Plain radiographs may show minimal joint space narrowing, little to no osteophyte formation, and mild subchondral sclerosis. CT scans can detect partial destruction of the femoral head before it becomes visible on X-rays. MRI is particularly useful, revealing bone marrow edema and changes in the femoral head and neck that suggest early joint inflammation and damage. These imaging techniques are essential for distinguishing RPOH from other hip pathologies. Distinguishing RPOH from other rapidly progressive hip diseases is critical. Conditions like osteonecrosis, subchondral insufficiency fractures, and typical osteoarthritis can mimic RPOH, but key differences exist. For example, RPOH usually presents with joint space narrowing before bone destruction, while subchondral fractures show a fracture line first. MRI findings and clinical presentation, such as the pattern of pain and range of motion, help differentiate these conditions and guide appropriate treatment. RPOH primarily affects older adults, with the average age of onset around 72 years. Women are at a significantly higher risk than men. Understanding these demographic risk factors can help clinicians maintain a higher index of suspicion in elderly female patients presenting with sudden hip pain, ensuring that RPOH is considered early in the diagnostic process. Recent studies highlight the importance of spinopelvic alignment in the development and progression of RPOH. Parameters like pelvic tilt, sacral slope, and lumbulordosis influence the mechanical stress on the hip joint. Increased posterior pelvic tilt and reduced lumbulordosis can concentrate stress on the femoral head, accelerating cartilage and bone destruction. Evaluating these biomechanical factors is essential for both diagnosis and intervention planning. Pathogenesis of RPOH involves complex cellular and molecular mechanisms. Early in the disease, synovial tissues show increased cellularity and hyperplasia, similar to rheumatoid arthritis. Elevated levels of matrix, MMP3, and pro-inflammatory cytokines like IL-6 and TNF-alpha drive cartilage degradation and bone resorption. Mechanical stress from spinopelvic malalignment generates cartilage fragments that act as danger signals, triggering inflammatory pathways and accelerating joint destruction. Key discovery in RPOH research is the role of the NLRP3 inflammasome, a protein complex that amplifies inflammatory responses. Cartilage fragments produced by mechanical stress activate toll-like receptors, which in turn stimulate the NLRP3 inflammasome. This leads to the release of inflammatory cytokines and enzymes that break down cartilage and bone. Targeting this pathway may offer new opportunities for early intervention and disease modification. Identifying reliable biomarkers is essential for early diagnosis of RPOH. Elevated serum levels of MMP3, as well as bone turnover markers like tartrate-resistant acid phosphatase 5B, have been linked to early femoral head destruction. Spinopelvic alignment measurements, particularly sacral slope and sagittal vertical axis, also correlate with disease severity. Combining biomarker analysis with biomechanical assessment may help predict which patients are at highest risk for rapid progression. Early intervention in RPOH focuses on preventing joint destruction before it becomes irreversible. While non-steroidal anti-inflammatory drugs are commonly used for pain, they do little to halt disease progression. New strategies target upstream events, such as correcting spinopelvic malalignment through exercises or surgery, and inhibiting inflammatory pathways like the NLRP3 inflammasome. Experimental drugs and biologics that block key cytokines or inflammasome components are under investigation, offering hope for more effective treatments in the future. Ongoing research aims to clarify the cellular and molecular pathways involved in RPOH, with the goal of identifying new biomarkers and developing targeted therapies. Randomized controlled trials are needed to test the effectiveness of candidate drugs, especially those targeting the NLRP3 inflammasome and related inflammatory cascades. As our understanding of RPOH deepens, the hope is to move from reactive treatment to proactive prevention, improving outcomes for patients at risk. Sum up: rapidly progressive osteoarthritis of the hip is a challenging and aggressive disease that demands early recognition and intervention. Key points include the importance of distinguishing RPOH from other hip disorders, understanding the role of spinopelvic alignment and inflammatory pathways, and utilizing biomarkers for early detection. By staying alert to the unique features of RPOH and embracing new diagnostic and therapeutic strategies, clinicians can help prevent devastating joint destruction and improve patient quality of life.